Welcome back to Therani, I'm Joe B. In this video, I'll show you how to correct foot overpronation. Say goodbye to pain and discomfort. Let's dive in. What are the signs and symptoms of foot overpronation? When you land on your foot during walking, running, or jumping, the ankle rolls outward with pain on the medial arch, eventually also bringing up about medial knee and calf pain. You will also notice a medial or lateral malleolar swelling or edema, as well as an increase in wear and tear in the medial border of the shoe. It can be due to congenital, increased body mass index, and or posterior tibialis muscle weakness. So how does the foot overpronation occur? It results in the tibia stuck in internal rotation, calcaneal eversion, subtalar pronation, and medial longitudinal arch depression. As a result of foot overpronation, to keep the lateral border of the foot flat on the floor, the talonavicular joint and calcaneocuboid joint has to supinate, which is a combination of plantar flexion, inversion, and adduction. Such talonavicular and calcaneocuboid compensations, or midfoot compensations, will result to forefoot compensations or first and fifth ray compensations. The talonavicular supination will result to first ray dorsiflexion, inversion, and adduction, while the calcaneocuboid supination will result to fifth ray plantar flexion, eversion, and abduction to allow the lateral border of the foot to be flat on the floor. In addition to the first ray and fifth ray forefoot compensations, stemming from the talonavicular and calcaneocuboid midfoot compensations, the second, third, and fourth ray now has to supinate in order to assist in keeping the lateral border of the foot flat on the floor or the ground, since overpronation can result to elevation of the lateral arch. In order to assess the presence of foot overpronation, we perform the squat test. The patient in this particular position will be standing shoulder width apart, arms at sides, head in neutral, trunk in neutral, and toes pointed forward. From this position, the patient is asked to squat as low and as comfortable as possible. If your patient has foot overpronation, the squat test will show either a genovalgum if the talonavicular joint, calcaneocuboid joint, first and fifth rays, and the second, third, and fourth rays are able to compensate to prevent the lateral border of the foot from rising from the floor. If the midfoot and forefoot joint compensations are unable to occur, then overpronation is worse and will result in the rise of the lateral border of the foot. Another assessment is an imaginary line through the shin. If it lines with the medial border of the foot, then that confirms overpronation. Once you confirm the presence of foot overpronation through squat test, it's time to treat. And the first order of treatment is mobilization in order to place the joints into proper alignment prior to provision of exercises. The patient is in supine position with feet close to the edge of the table. The therapist will be at the foot of the table facing the treated foot. The left hand is placed on the distal leg to stabilize, while the right hand index finger is placed on the cuneiform bone plantar aspect, while the middle finger would be on the navicular bone plantar aspect. The navicular and cuneiform bones are then supinated and held for 30 seconds for 3 to 5 reps. This is another angle of the mobilization technique where you can visualize the presence of the right index finger at the plantar aspect of the dorsal medial cuneiform. The right middle finger will be located at the plantar aspect of the navicular bone. And from there, the technique is delivered. After After mobilization, you can provide a postural exercise to counter foot overpronation, like a seated or standing foot doming. This can be performed by cueing your patient to keep the fourth and fifth toes flat on the floor while raising the medial longitudinal arch. The position is held for 5 to 10 seconds for 10 to 20 reps. An active range of motion exercise that can be performed is either a supine, side-lying, seated, or standing ankle inversion that can be done for 10 to 20 reps. To prevent muscle atrophy and facilitate strengthening exercises, the patient can be provided supine or seated ankle inversion isometrics. The tension can be held for 5 to 10 seconds for 10 reps. Eventually, this particular exercise can be progressed to TheraBand exercises, isotonics, isokinetics, and eventually to closed chain functional strengthening. If you like this video, please like, share, and comment. And for more therapy animations, please subscribe to Therani.